Welcome to Psych Talk. I'm your host, Dr. Jessica Rabin, a licensed clinical psychologist. If you are a mental health professional, student in the social science field, or just interested in psychology and mental health, this podcast is for you. Although topics discussed on this podcast are similar to therapy, Psych Talk is not a replacement for therapy and is for educational and entertainment purposes only. So let's dive into today's episode. Hey everyone, welcome back to Psych Talk, and thank you so much for joining me for today's episode. If you have been listening to this podcast for any amount of time, if you follow me on social media or are in the mental health community, you likely know that September is National Suicide Prevention Month. In 2008, September was officially designated as National Suicide Prevention Awareness Month to encourage open conversations, reduce the stigma surrounding suicide, and connect people to treatment services. In September, we also have National Suicide Prevention Week, which is an annual campaign to educate the general public about suicide prevention and warning signs of suicide. National Suicide Prevention Week always falls on the week that encompasses World Suicide Prevention Day, which falls on September 10th annually. World Suicide Prevention Day is an international event to provide worldwide commitment to ending suicides. It was established in 2003 by the International Association for Suicide Prevention. This year's theme of World Suicide Prevention Day is Changing the Narrative on Suicide. Per the International Association for Suicide Prevention, changing the narrative on suicide is about transforming silence, stigma, and misunderstanding into openness, empathy, and support. It is about encouraging individuals, communities, organizations, and governments to act with the following key messages: awareness and understanding. Talk openly and compassionately about suicide, challenging myths, and breaking down stigma. Policy. Advocating for the decriminalization of suicide and the development of national suicide prevention strategies. Action. Take part in training, share stories, and check in with loved ones. And conflict areas. Ensure those affected by crises and instability have access to mental health care and protective support. When I first started this podcast in 2020, I did my first episode on suicide during National Suicide Prevention Month, which was episode 21, entitled National Suicide Prevention Month. Then I did not make another episode on suicide until 2023, but received a lot of feedback from you all that you wanted more suicide episodes. So since the original episode back in 2020, I have released 6 more episodes on suicide. Episode 152, which was entitled 988, Suicide and Crisis Lifeline. Episode 154, Chronic Suicidology with Dr. Z. Seide. Episode 155, Interventions for Suicidal Behavior. Episode 174, Managing Suicidal Crises. Episode 205, Suicide Contagion. And episode 207, College Student Suicide. So today we're going to be talking about yet another suicide topic, which is youth suicide. As with all my suicide episodes, I am going to make the disclaimer that if suicide is a hard topic for you to hear about, and you do not feel like you are in a good space to listen to the episode, turn it off and go do something positive for you. I am always mindful about how I share information on suicide. However, with that, there are still things I cannot avoid talking about. Thus, it is okay to turn this episode off now or at some point throughout the episode if the content becomes too overwhelming. So first off, if you have listened to many or any of my past episodes, especially those on suicide, you know I will often start an episode with statistics to really highlight what we are talking about and the scope of the problem we are facing. So that is going to be how I start this episode. So in 2021, suicide was the 3rd leading cause of death among U.S. high school youth aged 14 to 18 years, with 1,952 suicide-related deaths, resulting in a rate of 9 per 100,000 youths. I should have also clarified before I jump into these statistics, as I am in the United States, these statistics are going to be related to the U.S. Suicide is the second leading cause of death for teens and young adults, ages 10 to 34. Suicide deaths among 10 to 24-year-olds increased by 62% from 2007 to 2021. Research released in the summer of 2024 found that suicide is rising dramatically in preteens as young as 8 years old as well, with an 8.2% annual increase from 2008 to 2022. The 2021 Youth Risk Behavior Survey found that among high school students, 20.4% seriously considered attempting suicide, and 9.5% attempted suicide. When looking at various groups of high school students, the percentage of those who have seriously considered suicide are as follows: 27.1% of female and 14.1% of male individuals, 41.0% of LGBTQ plus individuals, and 13% of cisgender and heterosexual individuals. 24.5% of American Indian or Alaska Native, 22.1% white, 21.6% multiracial, 19.6% Black or African American, 18.2% Hispanic or Latino, 16.1% Native Hawaiian or other Pacific Islander, and 14.4% Asian individuals. When looking at those same group of students but examining attempts, breakdown is as follows: 12.6% of female and 6.4% male individuals, 19.7% LGBTQ plus and 6.0% of heterosexual individuals, 15.3% of Native Hawaiian or other Pacific Islander, and 11.5% American Indian or Alaska Native, 11.4% multiracial, 10.8% Hispanic or Latino, 10.3% Black or African American, 8.3% white, and 8% Asian individuals. The YRBS found that approximately 1/3, which was 30% in their study, of female high school students and 14.3% of male high school students had seriously considered attempting suicide during the 12 months before the survey. The YRBS data from 2021 also revealed that over 42% of high school students experienced persistent feelings of sadness or hopelessness during the past year, and 29% of high school students reported their mental health in the past 30 days was not good most of the time or always. The prevalence among female students was higher than among male students for persistent feelings of sadness or hopelessness, so that was 52.6% versus 27.7%. Poor mental health, 38.8% in females versus 18.8% in males. Seriously considering attempting suicide, 27.1% in females versus 14.1% in males, and attempting suicide, so 12.6% in females versus 6.4% in males. Similarly, the prevalence among LGBTQ plus students was higher than among heterosexual students for persistent feelings of sadness or hopelessness, which was 65.7% versus 31.4%. Poor mental health, 53.5% versus 21.5%. Seriously considering attempting suicide, 41.0% versus 13%, and attempted suicide, 19.7% versus 6%. The prevalence of attempted suicide was higher among students in 9th grade compared to students in 12th grade, which was 10.4% versus 8%. Additionally, data collected during July 2021 to December 2022 on the Teen National Health Interview Survey of adolescents aged 12 to 17 years estimated that 21% of adolescents reported experiencing symptoms of anxiety in the past 2 weeks, and 17% reported experiencing symptoms of depression. Additionally, the 2023 National Survey on Drug Use and Health found that 12.3% of adolescents ages 12 to 17 had serious thoughts of suicide in the past year, and 3.3% of adolescents aged 12 to 17 attempted suicide in the past year. So I know I just threw a lot of statistics out for you, a lot of numbers, but hopefully the overall message that was communicated is that this is a significant problem for our youth. Which leads me to wanting to spend a little more time talking about the demographics that are at increased risk for suicide when looking at youth specifically. So the first demographic is boys. So as highlighted when I gave those statistics, girls are more likely to attempt suicide than boys, but boys are 4 times more likely to die by suicide than girls. And there are many reasons why boys are at an increased risk for death by suicide compared to girls. One is the cultural expectations of what it means to be a boy or a man. Traditional gender stereotypes often pressure boys to be tough and stoic and discourage them from expressing vulnerabilities or emotions, typically outside of anger. These pressures can result in them suppressing emotional struggles and suffering in silence instead of seeking help. Another related reason is the stigma associated with mental health and help-seeking behavior. So although there is stigma across all genders, when we take into consideration societal pressures and expectations of what it means to be a man, the stigma is often higher for boys. They may view seeking mental health care as weak, and therefore they do not reach out for help. Social isolation is another factor that may increase risk for suicide in boys. Research has shown that compared to women, men have smaller social networks and may feel more isolated than women. Boys are also more likely to use highly lethal methods, such as firearms, hanging, or asphyxiation, compared to girls, which makes intervention or rescue less likely when they make an attempt. Boys are also more likely to be impulsive than girls. Research shows that impulsivity is a key factor for suicide, and impulsivity may be more prevalent among boys than girls, particularly with those who have conditions such as ADHD, which we know is diagnosed more frequently in boys than girls. Substance use may be another risk factor for boys, as substance and alcohol misuse can be a coping mechanism for depression or other types of psychological distress and is a strong risk factor among males in general. Alcohol can also worsen feelings of hopelessness and increase impulsive behaviors, which we know both standalone are risk factors for suicide. Another youth demographic that is at higher risk for suicide are youth living in rural areas. So, suicide rates in general are often higher in more rural areas. The rate of suicide among youth ages 15 to 19 living in rural areas is 15.8 per 100,000 people, compared to 9.1 per 100,000 people living in urban areas. 65% of rural counties do not have a psychiatrist, and rural areas have fewer mental health providers in general, meaning individuals may not receive the necessary mental health care or they have to travel long distances for care. There are often also limited telehealth options due to lack of high-speed internet needed for virtual mental health appointments. Rural areas often have higher rates of gun ownerships and firearms as well. And as I just mentioned a few moments ago, that boys tend to use more lethal weapons. Guns, firearms are a more common lethal method for suicide in these communities. So we know if there's increased access to guns because there are more guns around, people are more likely to use a more lethal method when it comes to a suicide attempt, thus increasing the completed suicide at a higher rate in rural areas. There are also cultural and social factors that may play a role, including higher stigma for treatment-seeking behaviors, privacy concerns regarding seeking mental health treatment. And what I mean by that is rural communities tend to be smaller, more close-knit, and people are worried about other people basically sharing their business, talking about them, etc. And then a culture that emphasizes independence and self-reliance, which I want to emphasize is a positive trait in many ways. As somebody that went to grad school in a rural area, The values of independence and self-reliance can be very positive traits. However, they can also be negative when it comes to somebody struggling with their mental health. We also know that rural communities tend to be more isolated, which can lead to feelings of loneliness or lack of connectedness. And we know from research that isolation and feeling as if one doesn't belong, which in the research is called thwarted belongingness, can increase suicide risk. Another demographic that is at heightened risk for suicide among youth is LGBTQ plus young people. And the first statistic I'm going to share is actually an intersection of what I just talked about with rural youth being at increased risk, because LGBTQ young people living in rural areas are more likely to have considered suicide. So 43% of them compared to 38% in urban areas. Outside of LGBTQ youth in rural areas alone, 39% of all LGBTQ plus young people seriously have considered attempting suicide, and 12% attempted suicide in the past year. LGBTQ plus youth are more than 4 times as likely to attempt suicide than their non-LGBTQ peers. And while 72% of LGBTQ teens and young adults desire professional counseling, only 32% receive those services. I feel like I say this in every episode that I talk about the LGBTQIA plus community, but higher rates of mental health concerns and suicide in this community are not because somebody is LGBTQ plus innately. LGBTQ plus youth are at increased risk of suicide due to minority stress. So the minority stress model posits that LGBTQ plus youth experience mental health disparities due to victimization and the internalization of these experiences and anti-LGBTQ plus messages, which compound to produce negative mental health outcomes and increase suicide risk. A 2021 peer-reviewed study in the American Journal of Community Psychology found that greater experiences of minority stress are associated with increased odds of attempting suicide in LGBTQ plus young people. Another reason LGBTQ plus youth are at increased risk for suicide is rejection and lack of social support and affirming spaces. So, lack of parental acceptance is found to increase suicide risk and increase instances of depression in LGBTQ plus youth. And many LGBTQ plus young people lack access to affirming spaces, whether that be at home, school, or in their community. And research consistently finds that LGBTQ plus young people report lower rates of suicide attempts when they have access to LGBTQ plus affirming spaces. Physical harm and bullying also increase suicide risk in LGBTQ plus youth. 24% of LGBTQ plus young people report they have been physically threatened or harmed, and those who were physically threatened or harmed attempted suicide at a rate nearly triple the rate of those who have not been. Further, 52% of LGBTQ plus youth in middle or high school report being bullied either in person or electronically, and those who are bullied have 3 times greater odds of attempting suicide. Discrimination also plays a role in the increased suicide rates, with 60% of LGBTQ plus young people reporting experiencing discrimination based on their sexual orientation or gender identity at least once in their lifetime. And those who did experience discrimination attempted suicide at more than twice the rate of those who did not within the past year. And the last group of individuals I'm going to talk to you about that is at increased risk for suicidal behavior in youth are various racial and ethnic groups. So, for example, the suicide rate among Black youth aged 10 to 17 increased by 144% between 2007 and 2020, which is the fastest growing rate among racial groups. Black preteens ages 8 to 12 experienced the highest rates of suicide compared with other racial groups as well. A 2019 survey of Black middle schoolers found that 28% report suicidal ideation. American Indian and Alaska Native youth have the highest suicide rate among all racial groups in the United States. Research also indicates that Hispanic adolescents are more likely to attempt suicide than their white peers, despite reporting suicidal ideation less often, with the suicide rate increasing for Hispanic adolescents by 37% between 2010 and 2019. Some reasons for the increased suicide risk include systemic racism and discrimination, which contribute to feelings of hopelessness and depression, as well as subsequent suicide. Adverse childhood experiences, otherwise known as ACEs, may also contribute to their increased risk. Although anyone is at risk for experiencing an ACE or multiple ACEs, racially marginalized individuals are more likely to experience ACEs. Medical system inequalities and lack of culturally competent care also may contribute to increased risk. Racism in the medical system and implicit biases lead to misdiagnoses and underrecognized mental health problems in racially marginalized youth. Also, providers who lack the cultural training to understand how mental distress may present differently across racial and ethnic groups means that these individuals are often missed and do not receive the treatment they need, leading to increased suicide risk. Then there is also stigma associated with mental health and treatment seeking in many racial and ethnic communities that may discourage youth and families from seeking help. So I'm pretty sure by now I've established that suicide in youth is a significant health concern. It is a problem. We're seeing the rates increase, especially particularly among certain subgroups. And so I want to talk briefly about why suicide is the leading causes of death for youth, why we're seeing these increases. Um, as noted earlier, youth suicide is on the rise. Research has suggested various reasons this may be, including lack of access to mental health care, the pandemic, and concerns about violence and safety. I will get into specific risk factors in a minute, but I wanted to share some information about suicide trends in teens and why it is one of the leading causes of death for youth. So, a 2023 NIH report examining access to mental health care among youth found high rates of access to care among those who were identified as needing it. And when I say high rates, this study found 82.6%, which is really high. It also means that 17.4% did not get access to healthcare, even though they were identified as needing it. However, it should also be noted that this was a survey of parents and caregivers and only looked at those who identified needing mental health services. So it does make me wonder how many parents and caregivers maybe did not identify their child as needing mental health services, and therefore the number was inflated. A different 2023 survey, the National Survey of Children's Health Data, found that 54% of youth ages 12 to 17 have difficulty getting the needed mental health care. So very different numbers than we saw in the NIH report. The pandemic also contributed to worsening suicide numbers. So youth mental health was already experiencing a crisis before the pandemic, and many youth were underserved when it came to mental health care already. Then the pandemic exacerbated the mental health crisis and also, for some, limited access to services. I say all the time as a mental health provider, I do think one good thing that came out of the pandemic is we were forced to learn how to do telehealth. And for many, that meant mental health care or healthcare in general became more accessible. But like I said, rural communities, for example, may not have the high-speed internet. There are also privacy concerns. As somebody that works with primarily teens, the vast majority of my teens prefer to do in-person sessions. There's a lot of reasons for that, but one is privacy concerns because if they're living at their house with their parents or guardians or siblings, they feel like they can't be as open and honest if doing telehealth. We have also seen a trend over the years of teens using more lethal methods of suicide during their attempts, which is resulting in more deaths. And the cause for this increased use of more lethal means really remains unclear, but one hypothesis is social contagion and increased exposure to suicide. There's also some research suggesting that the sociopolitical climate and family financial strain may contribute to the rising suicide rates we have seen in youth. And then social media is another factor that may be contributing to the rise in suicide, not just because of access to information about suicide, which can contribute to suicide contagion, but also we see things like social comparison, cyberbullying, and measuring one's worth based off likes and comments. So now I'm going to talk about risk factors for youth suicide. Risk factors are anything that increase the likelihood of suicide. I mentioned many specific risk factors earlier when discussing the subgroups of youth who are at increased risk for suicide. However, I want to talk about more general risk factors. I do also want to note that many of these risk factors do not only apply to youth, but are risk factors for suicide in general. So the first one is probably the most obvious, and that is mental health conditions. So mental health disorders such as depression, anxiety, bipolar disorder, and substance use are closely linked with suicidal thoughts and behaviors. And it's estimated that about 90% of individuals who die by suicide have a diagnosable mental health condition. I also want to note that eating disorders also have a high rate of suicide, especially anorexia. Previous suicide attempts are another risk factor for suicide, specifically future suicide attempts, and is actually in the research shown to be one of the strongest predictors of future suicide attempts and death by suicide. Trauma, whether it be a history of childhood abuse or neglect or other significant trauma, can increase suicide risk. Chronic illness is another risk factor for suicide, specifically chronic pain disorders, as they can contribute to a sense of hopelessness and not wanting to live in pain. Poor emotion regulation and impulsivity are frequently found in youth who die by suicide. Discrimination and stigma, which I previously mentioned in the episode, are risk factors for suicide in youth, specifically those with marginalized identities. Bullying is a huge one, but interestingly, both being a victim of bullying and perpetrator of bullying are risk factors for suicide, and this includes cyberbullying as well. Lack of social support, whether this be from family or friends, increases suicide risk, as feeling isolated and disconnected from others negatively impacts mental health. Family conflict and instability, whether that be violence or conflict in the home, divorce or loss of a family member, all increase risk. Suicide contagion is another risk factor. As I mentioned at the beginning of this episode, I have done a whole episode on suicide contagion, so you can go listen to that to learn more. However, the premise is that another person's suicide, particularly of a family member or peer, increases the risk of suicide in vulnerable youth. Barriers to mental health care are another risk factor, whether that be difficulty accessing affordable mental health care, healthcare provider shortages, a lack of culturally competent healthcare, or stigma around seeking mental health care. And I want to note for youth, that can include parental stigma, which prevents youth from getting the mental health care they need. I can't tell you how many times I have heard from teens I've worked with, particularly either in the hospital setting or once they're like 16, 17, because in my state of South Carolina, you can consent to your own mental health services at 16 years of age, have told me they want therapy or want mental health care, but their parents don't believe in mental health care. They don't believe in mental health, and that has prevented them from getting the services they desire. And then lastly, a huge risk factor is access to lethal means. We know from the research, easily available lethal means, whether that be firearms or certain medications, significantly increase the risk of suicide among young people. So now for a more positive part of this podcast, if we can really identify any positive things on a podcast talking about suicide, I want to go over protective factors. So, protective factors are broadly defined as behaviors and characteristics of the environment that are associated with decreased likelihood for experiencing negative outcomes or are found to mitigate the negative effects of risk factors, such as exposure to adversity. With regard to youth suicide specifically, these are risk factors that would decrease their risk for suicide attempts or death. So, we just talked about factors that increase their risk. Now we're talking about factors that decrease their risk. So the YRBS that I mentioned earlier in this episode when discussing statistics found that all protective factors assessed in the study were significantly associated with lower prevalence of one or more mental health and suicide risk indicators. So, when looking at that study specifically, they found that being physically active for greater than 60 minutes a day on 5 or more days was associated with lower prevalence of having experienced persistent feelings of sadness or hopelessness. Getting over 8 hours of sleep was associated with lower prevalence of all mental health and suicide risk indicators, as was having a household adult who always tried to meet their basic needs. High parental monitoring was associated with lower prevalence of all mental health and suicide risk indicators, except poor mental health. High levels of school connectedness were associated with lower prevalence of all mental health and suicide risk indicators, and playing on one or more sports teams was associated with lower prevalence of all mental health and suicide risk indicators, except attempted suicide. Some of the additional protective factors include the presence of an important person in a youth's life. So, this could be a friend, guardian, teacher, or other significant person in their life. More broadly, a good support network can reduce suicide risk. This includes a supportive and caring family, which makes sense given some of the risk factors I previously mentioned. Coping skills is another protective factor. I always tell my clients that a coping skill is anything that makes you feel better when you're experiencing an uncomfortable emotion. So, when youth are more resourceful and skilled in problem solving, they are more better able to cope with stressful situations. If youth have a variety of effective coping skills, they are better able to handle such stressful situations and may view them as a challenge or an opportunity for change rather than feeling hopeless or stuck. Hobbies and activities are another protective factor. So, group activities or other hobbies and interests can be a protective factor for suicide risk for a number of reasons. So, one is that youth can channel their energy or frustration in a socially acceptable manner. This obviously depends on the activity, but if you're thinking about like sports, get you physically active, art can be a really good release, as two examples. Learn to relate to others, receive guidance from adults, and have structure in their day and improve their self esteem. Access to quality healthcare is a protective factor as well. I previously discussed how lack of healthcare is a risk factor, so it makes intuitive sense that access to quality mental health and medical services would reduce suicide risk. And then the last protective factor I'm going to highlight is limited access to lethal means. So, although one could easily argue that if someone wanted to end their life, they would find a way, reducing access to lethal means can reduce suicide deaths, even if it does not reduce attempts. Further, there is some research to indicate impulsivity is associated with suicide, which I already mentioned, suggesting that if there is access to a more lethal means, such as a firearm, and an individual who is acting on impulse could kill themselves a lot quicker than someone who is feeling impulsive but did not have access to lethal means, and then potentially would not even attempt due to a lack of access once the impulses pass, or would have to resort to less lethal means. Once again, not necessarily reducing attempts, but reducing the likelihood of death by suicide. So, next, I'm going to talk about warning signs. I have talked about warning signs in other episodes, so I'm not going to spend much time on this section. But note that not all youth who attempt or die by suicide will show these signs, and not all youth who exhibit these behaviors are at risk for suicide. But I do want to note that most youth who die by suicide do show some warning signs and behavior changes before their attempt. So, common warning signs include, but are not limited to, talking about killing oneself, feeling hopeless, feeling like a burden, or having no reason to live. Mood changes, including depression, anxiety, and agitation, and behavior changes such as increased substance use, withdrawing from activities, isolating from family and friends, sleeping too much or too little, giving away prized possessions, and irritability. I also want to note here, because a lot of people don't realize this, but when individuals, especially youth, are suicidal, suicide attempts tend to happen when they seem to be doing better. And so, what do I mean by that? So, there may be a youth who you're really worried about, they're showing these signs, they're having those behavior changes that I said. And then maybe for like a couple days or a week, they seem to be actually doing better. Maybe they're more social, maybe they're more talkative. Maybe they're not withdrawing as much. And that's the time you really need to be checking in on them. And so, one theory as to why suicide attempts happen on that kind of upswing is that they now have more energy to follow through with their plans. Another theory is that they are at peace with their decisions, so they're feeling better about it. But I always like to have that caveat as a psychologist that works with youth, and many youth who have been suicidal. I always get more concerned when a chronically suicidal teen is telling me initially that they're feeling a lot better, not having thoughts of suicide. And that's where I'm checking in more. I'm not saying that's always the pattern. Some might start feeling better, whether that's therapies working, medications working. They've identified reasons to live, things like that. But I do want anybody listening to this episode, especially if you have youth in your life, to be aware of that upswing. That's not the time to be like, oh, they're doing better and ignore them. That's definitely time to still be checking in, engaging them in activities, all of the things that hopefully you're already doing with them. Which leads me to my last section that I want to talk about, and that is how can we help reduce youth suicide? So, generally speaking, educating yourself on warning signs, risk factors, and protective factors is a good place to start so you know what you are looking for. It is also important to get comfortable with talking about suicide and asking the person if they're thinking about suicide. I want to validate that it is uncomfortable for many people to talk about suicide, but the best way you can do it is asking in a direct manner without any judgment. So, explicitly stating, hey, I've noticed X, Y, and Z behaviors, or hey, I've noticed you've been seeming more depressed lately. I want to ask, are you thinking about hurting or killing yourself? If they say yes, you want to clarify. Are you thinking about hurting yourself or are you thinking about killing yourself? You don't even have to say hurting yourself. You can just say, are you thinking about killing yourself? Or you can phrase it in a way, I've noticed you've been depressed lately. A lot of times when people are thinking or feeling depressed, they're thinking about taking their own life. Is that something you've been thinking about? So you want to ask in a direct manner. And when I say without any judgment, you don't want to say something like, you're not thinking about killing yourself, are you? Because that communicates that you're not a safe person. If you ask in a direct manner, in a compassionate manner, it can help individuals feel more comfortable talking to you about how they are feeling. It's also important that you are aware of resources that can help, including crisis line numbers. So in the United States, 988 is the National Suicide Lifeline. However, we have many more numbers as well. I've made a number of social media posts on various numbers, including one at the beginning of this month, if you are listening in real time, that is posted on both my Instagram and TikTok. I also have numbers pinned on my TikTok as one of my pinned posts. Um, it's also important to know if your area has a mobile crisis unit, what the local hospitals are, maybe therapists or other mental health resources that you can check out. Now I'm going to talk about specific demographics of people that can help. So first, let's start with parents, because if we're talking about youth, hopefully they have parents or guardians that are involved in their life. Family involvement is vital when it comes to the care and intervention for a youth experiencing suicidal thoughts or behaviors. Parents should be aware of warning signs of suicidal behavior as well as mental health concerns in general. Parents should also be involved in safety planning for their child. So, developing effective educational measures for families of suicidal youth is another way parents can help prevent suicide. There are also family relationship programs such as Strengthening Families 10 to 14, which teaches adolescents and their families about risk and protective factors associated with suicide and enhance their problem solving skills for dealing with adversity, stress, school, and other problems. Strengthening Families 10 to 14 also improves parents' skills for disciplining, managing emotions and conflict, and communicating with their children. It also promotes youth's interpersonal and problem solving skills and creates family activities to build cohesion and positive parent child interactions. Next, I want to talk about schools. I do want to start by saying and validating that schools often struggle to meet the growing mental health needs of young people, with one survey from the National Center of Education Statistics finding that 53% of public schools report a rise in students seeking school-based mental health services compared to previous years, but only 52% of public schools said they are effective in providing mental health services to students in need. Common barriers schools face in providing services include inadequate funding, lack of qualified mental health care providers, and a need for more trained school staff to support students in need. So I recognize what I'm about to say may seem impossible. However, if able, schools should do what they can to support student mental health and suicide prevention. 91% of school administrators feel that schools should make efforts to prevent suicide among students. Similarly, 92% believe that schools should make efforts to identify high school students in need of mental health services. This may include training teachers to identify mental health system and warning signs of suicide. I also think it is great when schools can integrate school social workers or therapists into the school so that it increases access to mental health services for students in need. Once again, acknowledging that not all schools have the funding to do so. JED also has a comprehensive approach to mental health promotion and suicide prevention that schools can look into, which involves partnering with schools and other organizations to develop data-driven, customized mental health strategies aligned with their unique culture, youth needs, and capacities. Next, let's talk about friends. What can youth's friends do? So, in addition to recognizing warning signs and talking to their friends about suicide, friends play a vital role in suicide prevention for youth, as they are often the first ones to know about their friends' suicidal thoughts or behaviors. As if we're thinking from a developmental perspective, peers tend to confide in peers more than they do with their parents or guardian. If a friend does disclose suicidal intent, it is important not to keep it a secret. I understand the friend may be mad at you or there is fear that you will be breaking their confidence, but it is a necessary step to get them help. It is important to confide in a trusted adult about your friend's suicidal thoughts and behavior. When a friend talks about their suicidal thoughts, listen with empathy and provide support. You don't have to know the right things to say, but by listening and validating their experiences, empathizing with them, and not minimizing their feelings, it can be a big help. It is also important never to dismiss what someone is saying when it comes to suicide. Friends can also be a role model for reducing stigma and encouraging help-seeking behaviors by encouraging their friends to reach out for help. I've said this multiple times, probably on the podcast, in real life, on social media. Like, I am amazed by Gen Z, and I think Gen Z is going to do a lot of good for the world in many capacities. But as somebody that works primarily with Gen Z, how open they talk about mental health and how open they talk about therapy with their friends is very admirable. And so if a friend maybe is worried about seeking help or doesn't know how to talk to their parents about it, especially if you've had experience in therapy or know somebody that has, show them how you benefit from therapy or how you talk to your parents about getting therapy or go with them to talk to their parents or guardian about therapy. There's a lot that friends can do to help support one another. Next, let's talk about professionals. So, the American Academy of Pediatrics now recommends universal suicide screenings for youth above the age of 12, meaning that preteens and teens should be screened for suicide risk even when seeking healthcare for unrelated concerns. These screenings involve asking questions such as, in the past few weeks, have you wished you were dead? Or in the past week, have you been having thoughts of killing yourself? Once again, very direct in nature. By implementing universal screening, we can better identify youth at risk for suicide. However, screenings do not always provide a reliable assessment of a child or adolescent's risk for death by suicide. A patient screens positive on a suicide screening tool when they answer yes to questions asking if they've had suicidal thoughts or behavior. But even with a positive screen, it's not always clear to the healthcare professional providing these screenings what kind of treatment and follow-up are needed. This is why training healthcare professionals on suicide warning signs and risk factors, suicide screenings, and local resources is immensely important. For mental health professionals, diversifying the workforce to increase the number of providers from underrepresented communities can help build trust and improve the quality of care. Cultural competency training for marginalized individuals who are at increased risk for suicide, so LGBTQ plus youth, racial ethnic group, even boys, I would argue as well, can help with improving quality mental health care that youth receive. Providers also can play a role in preventing suicide through advocacy, research, and education. At the community level, we can implement programs such as Sources of Strength, which is a youth-based program which has shown to increase perceptions of adult support for suicidal youth and acceptability of help-seeking behaviors among high school students. We can implement social emotional learning programs such as Youth Aware of Mental Health. And then we can train gatekeepers, which are community members such as teachers, coaches, or healthcare providers who are trained to identify persons who may be at risk for suicide and refer them to treatment or support services. Then we have the systems level, and we cannot talk about suicide prevention without addressing systemic issues that can contribute to increased risk of suicide. We need to address racism. We need to address poverty, housing instability, healthcare inequality, among other systemic issues that contribute to elevated suicide risk. We also need to address how suicides in the media are reported to reduce the likelihood of suicide contagion. Luckily, there are media guidelines that can help with safe reporting. Obviously, systems level change means getting legislators involved, advocacy. It means writing your representatives, voting for politicians who value mental health and want to make these changes. So that's where I'm going to end on today's episode. Thank you for sticking with me through it. I know suicide is a difficult topic for so many to hear about, but it is an important topic to discuss. So I'm glad you are here with me. I hope this episode was informative. And if you found it informative, please share this episode on your socials or with somebody you think may benefit from hearing it. As always, please rate, review, and subscribe to the podcast. And I will see you in the next episode. Bye. Thank you for listening to today's episode of Psych Talk. Please rate, review, and subscribe to the show. And if you enjoyed today's episode, please share it with a friend. Don't forget to follow me on all socials at Jessica Lee, PhD, and the podcast at Psych Talk Podcast on Instagram.